The topic we are going to be covering is quite huge. It's an anterior abdominal wall defect, but what I've just decided to do is because my other presentation is refusing to open since I came here almost 7 o'clock, but since 7 o'clock, my internet is freezing and refusing to open my full presentation of this topic. Maybe it's because it's too big a volume. So what I've done is I've gone to my common fetal defects file to focus mainly on the 3 commonest conditions today. Then next week we'll be able to cover the other anterior abdominal wall defects, the other anterior abdominal wall defects and gastrointestinal tract abnormalities. Right. So anterior abdominal wall defects, basically saying defects of the formation of the anterior abdomen. I will cover embryology when my full presentation shows up next week. But to just remind you that during the formation of the baby, the abdominal wall, how is it closed? How does it become closed? It is closed through the flaps that come from the side and they fuse at the center. The skin flaps come from the side and they fuse at the center. This is how the anterior abdominal wall is covered or formed. Then within the anterior abdominal wall, we have a landmark structure, which will overemphasize next week on my full presentation, which is the cord insertion on the abdomen. As you, this is the abdominal cord. This is abnormal. What you are looking at, slightly. This is not normal, right? So we have the cord which inserts on the abdomen. So the cord insertion becomes a very important landmark in screening for anterior abdominal wall defect. Let me see if I have that slide here. I think it should be the slide which shows you that should be open. Let me see if I can. I'll just stop the share for a brief. Then I want to show you the image with which shows the anterior abdominal wall. Let me see if it's, because I think that part was open somewhere. Do I have it? Let me see this one. Should. Sorry, my computer is misbehaving. It's actually freezing all the time. Right, I'm not sharing a screen there, but I can't move the slide now. I think I need to change my computer in the new year because it's no longer performing well. Right, so so the abdominal cord insertion becomes a very important landmark that everyone who scans should be able to do. Like we said, that you cannot be working in the fetal medicine unit and you are not able to screen for common fetal defects. It doesn't make sense. It doesn't make sense because the fetal medicine unit is more of a quaternary unit. Quaternary unit means that is the center where diagnoses, abnormalities are supposed to be picked. So what becomes very important when you are doing the usual screening scan, after taking your abdomen, the abdominal circumference, and you go down on the baby, I'm not sure if I do slideshow properly, whether my machine will manage, because it's giving me a headache. When you go down, you are going to arrive at the position of the abdominal cord insertion you see there, where my cursor is right there. You will see 3 lines. That is normal. So the abdominal cord insertion is signified by those 3 lines. This is a very important image in screening for anterior abdominal wall defects. This is just to demonstrate the same image in color here. So that's the kind of image we need to screen for anterior abdominal wall defects. If you are able to do that image, there is no way you are going to miss a gastroschisis, and there is no way you are going to miss an exophallos. Look, both exophallos and gastroschisis are conditions that need surgical intervention after birth. There are certain conditions you can miss, but there are certain conditions you cannot miss. You can't miss a gastroschisis because imagine at birth, and look, they may actually be born at the wrong hospital, and if they are born at the wrong hospital, they will die. Because the wrong hospital will not know how to manage them. They will lose electrolytes, they will lose the fluid, they become hemodynamically unstable, then they will get the infection and they will die. Because we have missed a very dangerous condition, which is gastroschisis. I know my screen has just disappeared. I can see it from the other gadget, but I think it's coming back. I'm trying to just enlarge those images in a slideshow. So the same with the exophallos. We cannot miss it if we go and look for those 3 lines. These 3 lines, we identify them when we continue to move the probe after checking the abdominal circumference. So when you do your abdominal circumference today, try to scroll down in a straight line to just slide your probe in a straight line. Certainly you are going to arrive at the position of the abdominal cord insertion. That's a very important image in screening for abdominal wall defects. The second image, which will come out just now, I think it's just taking time to bring the slideshow. The second image is the image we get at the level of the bladder. When you continue to scroll down and we see the bladder, and we try to sort of rotate towards the anterior part of the baby, we will be able to demonstrate the bladder in the 3-vessel view. We do not need the 3-vessel view really to screen for anterior abdominal wall defects, but the non-visibility of the bladder, because the bladder should always be seen. If you don't see the bladder, there is a problem. So the bladder should always be seen. What will the bladder do? The bladder will allow us to screen for the lower. Remember the upper, which you will describe this more next week when you classify them. The what we call upper abdominal wall defects, then the middle abdominal wall defects, and the lower abdominal wall defects. What I presented here is the screening of middle abdominal wall defects, which are gastroschisis and exophallos. But when you come to this image on the bladder, we are now screening for lower abdominal wall defects. It is not just the gastroschisis and the exophallos we are trying to rule out. We are trying to rule out all the anterior abdominal wall defects, or anterior, let me say anterior wall defects, because the defects will start at the level of the thorax, going all the way to the bladder area, to the bladder area, right? The suprapubic area there. So all those defects are possible, and they should be screened for using ultrasound. So what you are seeing on the screen are basically the 2 images that we need to be able to screen for most anterior abdominal wall defects. Of course, we also need the image of the chest at the level of the 4-chamber view to be able to say we have screened for anterior abdominal wall defects. Right. So to just I don't know what's happening to my to my computer there. To just go through it again, we're saying when you are doing abdominal circumference and you go down, you are going to see these 3 lines. You should always see them. If you don't see the 3 lines, there is a problem. Don't normalize things. If you don't see the 3 lines, recognize that the abdominal wall may be having a problem and you refer. But the 3 lines should be seen. These 3 lines represent the cord insertion, umbilical cord insertion here. As we are demonstrating with the color, here we are picking the 2 umbilical arteries. But remember, there are 3 vessels here, right? We have these 2 umbilical arteries, and we also have got the umbilical vein. Then when you come down to the baby's pelvis, you're going to see the bladder. This is the bladder here, shown by the arrow. You may need these colors, but you don't need these colors to show that there's a bladder. These colors help us to pick a 3-vessel cord. It's a very important part of anomaly screening because a single umbilical cord is associated with either chromosomal defects or defects of the kidneys or other defects. So picking that up is very important for us. So remember, before you know how to diagnose, you should know how to screen. So these are the images required to screen for most anterior abdominal wall defects. The bladder should always be seen. Okay, sorry, I'll exit this because that's not where the other presentation is. I'll just go back to where I was. Right, so let's go back. Right, so if you look at the screen which is now coming to you, we are back to where the exome valus is. So the exome valus, you can see that let's say you are trying to do abdominal wall image, and all you can see now are something that looks like 2 abdomens. The reason why it's looking like 2 abdomens is because there is a defect on the anterior abdominal wall here that has allowed the organs of the abdomen to herniate outside their normal location. And what you are looking at here is the liver. That's the baby's liver. There is the liver. And of course, probably some bowels, and sometimes we may have stomach in it. This is what you are seeing being represented here, right? So an exome valus will have a sac covering, and it's well circumscribed, this sac. You can see that the same sac here on this baby. This was one of our baby we saw. This was a what? Perinatal baby. I can't remember if perinatal or private. I think this was a perinatal baby. Yeah. So you can see the membranes covered, and you can see there is bowel and the liver in it. So this defect, we don't know why it occurs. We just think it's due to malformations, teratogens, multiple other factors may contribute to the failure of the anterior abdominal wall to close properly. I told you the closure comes from the sides. You see when you look at the embryo that in the beginning it's open, but it has to close. So if it fails to close, we end up with an exome valus or an omphalocele. So normally the umbilical cord is at the apex of the dome or the dome of the sac, but it's not always the case. I know books write it this way, but it's not always the case. As you can see from our patient here, that it was not necessarily at the top of it, right? It was more like on the side. So I know this criteria is written in the books, but what I'm saying from our clinical experience, this is one of our cases you see there. It was not like that in that case. As you can see, it was different. So it's not always the case. Exomphalos, how common are they? They are as common as 1 in 2,000 at 13 weeks. But however, if you look at the prenatal figures, they look like they are rare. Why? Because exomphalos babies are associated with trisomy 18 or 13 in 30 to 50% of the cases. So most of these babies are miscarried or terminated in countries that have got early prenatal diagnosis. And the reportage at birth underestimates the actual problem for fetal medicine people like us. So for you, you have to know that this is as common as 1 in 2,000. But also be aware that exomphalos can be physiological. Physiological in the sense that it will commence, because I told you naturally, the bowels are outside when the baby starts forming as early as 5-6 weeks there. But it is the bowels have to go back inside by 12 weeks. So if you scan babies at 10 and 11 weeks, they are going to see what you call a physiological exomphalos. Please do not make the women panic, because I know the moment you begin to look for these things and become more clever, you are going to begin to see things that you were not seeing before. So if you scan between 10 to 11 weeks, you are going to see a physiological exomphalos. There is nothing to write home about a physiological exomphalos. You may ask the woman to come back at 13 weeks so that you can check if it has gone back, because the majority of them go back. But if it is persistently present at 13 weeks, then in that case, it's highly unlikely to go back. And this patient has to be referred to the fetal defects clinic for evaluation and also to be offered prenatal diagnosis. That means to be offered invasive testing like amniocentesis to rule out chromosomal abnormalities. Because I've already told you that if we see trisomy, if you see exomphalos, you should know that the baby could have Edwards or Patau syndrome in 30 to 50% of the cases. So almost half of the cases, or almost between a third to a half of the cases with exomphalos will have trisomy 18 or 13, which is Edwards and Patau. We know that these chromosome abnormalities are stubborn and very bad. So then the condition itself, unfortunately, it is associated with other defects in most of the cases, like our baby there, who also congenital diaphragmatic hernia. But one of the most common associations with exomphalos is kyphoscoliosis. Kyphoscoliosis, the abnormal shape of the spine, the baby's spine. So whenever we screen for exomphalos, we cannot say we have finished checking the baby without evaluating the spine. The spine of the baby has to be assessed because they have kyphoscoliosis in most of the cases. So the spine is very important to check in cases of exomphalos. The second thing is that there is association with cardiac defects. So the heart has to be checked. Normally, if there is association with cardiac defects, then you know that the likelihood of trisomy 13 or 18 is very high, and the association will be very high. And these babies certainly have to be offered karyotyping. For an exomphalos, when we say an exomphalos, what kind of description will help with the postnatal prognostication? We want to know if the sac contains the intestines only, or there is a liver involved. The bigger it is, the more trickier it is in terms of the size. And also the bigger the involvement of the liver, also complicates issues for these babies. So this is something that you also have to be aware of, that the involvement of the liver will complicate things compared to the involvement of the bowels alone. So that has to be reported. Whenever we're scanning eosinophils, we want to know, is the liver involved or not? The other issues we may want to comment on involves bowel dilatation, whether the stomach is in there or not. In very rare and extraordinary circumstances, this is common, right? No, not for this. So we want to know if the stomach is in there or not, in the sac, and yeah. So that has to be reported. In isolated small cases where the liver is not involved, the survivor is very good for exomphalos. When we are saying isolated, remember, we are saying we've ruled out other defects like cardiac defects, and we've also ruled out chromosomal defects like trisomy 18, 13, or even Down's syndrome. So you cannot say something is isolated if karyotyping has not been done, because you can potentially miss a baby with trisomy 13 or 18, and trisomy 18 and 13 have got high perinatal mortality. Delivery is timed around 38 weeks. Like all other fetal defects, where there is no fetal compromise, the delivery is around 38 weeks. You may ask and say, why do you have to know this information? Because you have to be more richer than probably you are at the moment in terms of your information package, which you can share with your clients. Modern medicine requires that you give enough information to patients. It's not good enough in modern healthcare. Just tell people that your baby is abnormal and you stop there. You need to know this information so that you can have a rich discussion with your patient. If you don't know information, then you have no basis to discuss issues. So this is why it's very important to know this kind of information, because some of you may think we are putting too much weight to your brain. But look, these are the demands of modern medicine. Modern medicine requires that you know. Yeah, you cannot be a technician, no. So that is exomphalos. Very important defect. Everybody should be able to recognize it, right? Let me go to gastroschisis. Probably I'll just cover the two today, because the others will cover them. We have to finish the anterior abdominal wall defects first, then we'll go to the internal abdomen defects. Gastroschisis. As you can see, again, you have just done your abdominal circumference, and you want to get your three vessel view. Those three vessel, not three vessel view, but those three abdominal cord insertion, and you want to see those three lines. And all you are going to meet suddenly is this. You are going to see these bowels floating within the amniotic cavity. You can see there's a difference with an exomphalos in that there is no nice membrane covering. It's just bowel floating everywhere. And it will be like this. So this is gastroschisis. The gastroschisis is thought to occur as a result of some thrombosis that happens on the right side, on the left side of the abdomen, close to where the cord is inserted. And the herniation is going to be on the right side. So there's going to be herniation of bowel on the right side of the umbilical cord. The umbilical cord is still attached at the level of the abdominal wall, unlike in the exomphalos. and you are going to see free-floating loops of bowel. In terms of what may go out, in most cases, it is the bowel. In rare cases, it could be the abdomen. In extremely rare cases, the liver may go out. But in most cases, it is the bowel that goes out. It is fairly common, 1 in 3,000 at 13 weeks. If it is isolated, which is the most common cases, it is a very good prognosis. What do we have to watch for? We have to watch for dilatation of the bowels. Sometimes the intra-abdominal bowel, the one that remains, may be dilated, or the extra-abdominal bowel may be dilated. The bowel may strangulate itself on itself and dilate. Unfortunately, this may not be a good sign. What it means is that that bowel may not be functioning well at birth, and it may have to be removed, and which will lead to a condition we call small bowel syndrome, where the baby will struggle to manage electrolytes, and these babies will undergo what we call failure to thrive. When we meet gastroschisis babies, we want to follow them up every 4 weeks. My God, I think my computer is shutting down, but I think we have all the information. I'll continue from my phone here. We want to see them every 4 weeks. Okay, I have the opportunity to cancel. So we want to see them every 4 weeks whenever we meet gastroschisis babies to check for growth. These babies, both gastroschisis and somehow they do not grow well. They are fetal growth restricted. And because the abdomen is not normal, a formula which is supposed to be used to calculate the estimate of fetal weight is Callen's formula. We do not have it in the machines, unfortunately. And we end up just calculating with the machines, with the usual formula, which grossly underestimates the weight. So be aware that the weight you are getting from both gastroschisis and exomphalos is an underestimated weight. Gastroschisis is not commonly associated with chromosomal defects like Downs, Edwards, and Patau. If it is in isolation means is the only defect we can see. But of course, if there are other defects, then association cannot be ruled out. It will be possible for it to be associated with chromosomal defects if there are other defects identified during the scan. So, in brief, I've taken you through the through gastroschisis and exomphalos. These are two common defects. The others are not as common as these two, but we are going to cover all the others, from the pendology of Cantrell to bladder extrophy and cloacal dystrophy and so forth. We're going to cover all those next week, the anterior abdominal defects. But these are the most commonest. Everyone should know how to screen for them, because if you know how to do abdominal circumference, and if you know how to do a femur, certainly you can obtain those two screening images, which I displayed on the screen. That is to screen for gastroschisis. I think if I'll stop here, unless if there are any questions. Then next week we will proceed with the anterior abdominal defects and probably cover. I will try to cover probably the whole topic next week, so that when we take a break, we don't come back with for the same topic. Any more questions? If there are no more questions, if there are any, you can also use the group to share. Otherwise, bye-bye and enjoy the weekend.